Good afternoon, everyone. Thank you for allowing me to present the study done at our institute. I shall be talking about Sphingomonas paucimobilis related lacrimal infections. Informed consent for all photographs were taken and there are no financial disclosures. Holmes and colleagues in 1977 first reported infection by Sphingomonas paucimobilis, an opportunistic pathogen then known as Pseudomonas paucimobilis, which belongs to the Pseudomonad group of bacteria, which is a strictly aerobic gram-negative bacillus, which is yellow pigmented and non-fermenting. It derives its name Sphingomonas from the special sphingoglycolipid in its outer cell wall, and paucimobilis from the limited motility due to a polar flagellum. So why are we talking about Sphingomonas? Though it is ubiquitously present in the natural environment, it has been increasingly isolated from hospital ward systems, hemodialysis units, respiratory equipment, and ventilators, and is being increasingly implicated in hospital-acquired infections. Infections reported have varied morbidity and mortality, including cases of bacteremia and sepsis. And ophthalmic infections, including endophthalmitis and keratitis, have also been reported. Although very rare, fatalities have also been reported by this bacteria. Hence, we decided to look into the armamentarium of its involvement of the lacrimal drainage pathways. Ours is a retrospective chart review of all the patients who were diagnosed with Sphingomonas paucimobilis lacrimal infections, managed from November 2015 to May 2022, and included a total of 11 participants. So the collected data was analyzed under two groups, canalicolitis and acute dicryocystitis. The microbiological examination was undertaken on the pus or discharge from these patients and was subjected to routine microscopy and culture in solid media. The confirmatory diagnosis was done using Vitek 2 compact system. This here you can see the off-white yellow pigmented colonies which are growing on blood agar and chocolate agar. This is a representative image of the usage of Vitek 2R compact system, which we used for the confirmatory diagnosis. The patients of canalicolitis were managed with topical antibiotics, punctal dilatation with non-incisional curettage, and recalcitrant cases underwent punctoplasty. The cases with acute dicryocystitis were managed with systemic antibiotics after sending the sample for microbiological evaluation, and the treatment was reassessed and modified further depending on the susceptibilities. Patients with lacrimal abscess underwent incision and drainage and intensive care using systemic antibiotics and monitoring. Definitive management in this group of patients was done using either an external or endoscopic approach of dicryocysto rhinostomies. So a total of 11 patients were included in the study, of which 5 belonged to the canalicolitis group, and they presented most commonly with a swelling over the involved canaliculus or a discharge and peripunctal erythema. Patients in the dicryocystitis group comprised 6 patients, and most common presentation was a swelling over the lacrimal sac area, followed by proptosis, pain, and lacrimal fistula. So in the canalicolitis group, we had a mean age of presentation of 62.5 years, with males being more commonly involved, and a predilection for the left eye and the upper canaliculus. In the dicryocystitis group, the mean age at presentation was 40 years, with females being more commonly involved and the right eye being majorly affected. This here you can see the antibiotic susceptibility pattern, where we can see it is mostly sensitive to all the antibiotics, most sensitive being to piperacillin tazobactam, ceftazidime, and gentamicin. So the canalicolitis group responded to punctal dilatation and non-incisional curettage. Only one patient had to undergo 4-snip rectangular punctoplasty, whereas the dicryocystitis group responded to the systemic management and a final surgical approach using endoscopic or external cystectomy was endoscopic or external dicryocysto-rhinostomy was done. One patient was lost to follow-up in each group. So the special characteristic of Sphingomonas is that it lacks the outer lipopolysaccharide layer and is replaced by sphingoglycolipid, which is considered to be less immunogenic. It also can form biofilms and can pass through 0.2 micron filters, which explains its increasing predilection in hospital-acquired infections. So in literature, we see that in the ophthalmic involvement, mostly endophthalmitis and keratitis patients have been reported. On digging deeper into the literature, we found that only 2 papers had mention of Sphingomonas as a cause of canalicolitis. To summarize, out of the 15 cases that have been reported, canalicolitis was reported in only 3 of them, all of which resolved on conservative management, and the patients had similar antibiotic sensitivity profile. So this study highlights that it is one of the this is till date the largest study of Sphingomonas paucimobilis related lacrimal drainage infection, and it elucidates the spectrum of infection in these patients, which range from canalicolitis to acute dicryocystitis with or without lacrimal abscess and orbital cellulitis. An empirical treatment is usually helpful, and it helps in resolution of symptoms, but we should be mindful of the complications which can happen, the fatal So to conclude, I would like to stress on the fact that Sphingomonas paucimobilis infections, though rare, are on the rise, and bacteremia and sepsis have been reported in these cases, and hence we need to take proper management plan in these patients, and the outcomes are usually good with multimodal management. Thank you.
Excellent study, but for record you exceeded the time limit.
Yes, sir. Sorry.
This one. And has this study or part of this study been published already?
Yes, sir. It was recently published, actually.
So it is the treatment is only medical treatment you are advising?
So no, actually surgical intervention was required in a few number of patients. In canalicolitis only.
But in the acute case, are you going to inject it surgically?
No, sir. In the acute cases, all the patients were first treated with systemic antibiotics or incision and drainage in lacrimal abscess patients, and then it was followed up by the surgical intervention.
In all cases of this type of lacrimal area, you try and get the settle. From where you can get the settles?
Yes, sir. From the incision and drainage. Yes, sir.
All the cases.
Yes, sir. Wherever there was abscess, which was there, we did a sample study like that.